biopsy. Serological tests are three typical ones: TTG antibody, anti-endomysial, and anti-gliadin. For all practical purpose, you remember one, TTG, that is tissue transglutaminase antibody, because it is an ELISA test, easily reproducible, can be done. Anti-endomysial, more sensitive, but a bit difficult to do. The NEGM study had quoted that the sensitivity of TTG is to the tune of 92 to 95%, almost for ELISA test. And endomysial, though high, but in India we don't find because it is difficult to do. Anti-gliadin antibodies, not very useful because they can be seen in other. But if you have IgA deficiency, go for anti-gliadin IgG test. So in those patients who have IgA deficiency, most of my tests are going to be difficult to pick up. So you have to have a clinical judgment, and maybe you can use the biopsy and genetics if need be. So the main key test that you want to do, one test to diagnose it, would be an endoscopy. What do you see on endoscopy? You can see how edematous, irregular surface, that is called scalloping of the duodenal folds. When you see on endoscopy this type of picture, unless proved otherwise, it is malabsorption. It could be celiac, maybe chronic giardiasis, maybe tropical sprue, unless I see the biopsy. So what does the biopsy show? Typically on biopsy, you find finger-like projection called the villi. What will happen in celiac? You will increase IEL, the lymphocytes increase and the villus get atrophic. So if you find villus atrophy like this in a patient with increased infiltrate, that is celiac disease. So you will have to do this criteria. What are the criteria? History is suggestive of celiac disease. Examination is like that. Serology was compatible, but as I said, 5% you might miss the serology. Then the biopsy, histological findings, and then most important thing, after having diagnosed, you put the patient off gluten, and there is a complete response. Whatever whether anemia, constipation, diarrhea, thyroid, diabetes, everything shows a response. So that is the key thing. Clinical and serological response. How do I follow my patients? I keep doing the TGA. If the TGA is not controlled, diet is somewhere compliant, not compliant. So you give them a gluten-free diet for the life. Temporarily, I will withhold milk because the villi are blunt. The enzyme is deficient. Once the villi redevelop, we'll restart the milk. And we'll supplement all the vitamins and minerals and etc., trace elements, calcium, iron, etc. Now I'll just give you pictures. This is a child coming from a very good family. She's presented with diarrhea and dyselectrolemia. She came with markedly high. And within treatment, she improved. How beautiful she is post-treatment with celiac disease. This patient coming to you, severely malnutrition with fracture. She was basically a patient of celiac disease. This patient had a scar, had abdominal distension, obstruction. Somebody did a surgery for that for obstruction, but actually it was a patient of celiac disease. This patient just weight and height not gaining, short coming. Their abdomen is still not distended, but their height and weight are not increasing. This patient, no diarrhea, coming to you just with height, just short stature. When you find out, they turn out to be celiac disease. This patient's turning out with abdominal distension. It could be mild, it could be moderate, it could be as loud as this, significant abdominal distension. It could be just anemia. Patient is going pillar to post. I've had patients diagnosed as hemolytic anemia getting recurrent blood transfusions. They turned out to be celiac disease. Patient coming to you with purpuric spots, bone marrow done, trying to rule out malignancy. It was just vitamin K deficiency, celiac disease. Diabetes, sugar not controlled, check for celiac, celiac disease. Thyroid, not doing well, check for celiac, celiac disease. Patient identified, SIB screening. 10 to 15% of the SIBs will, obviously it is the same genes, so 10 to 15% of the SIBs will have. What did I do? Screen the SIB, identified. So SIB screening. So having said that, you could have unusual presentation. Something like this, the patient presented with joint pain, swelling, fever, rash, seen by a rheumatologist. The rheumatologist diagnosed as systemic onset rheumatoid arthritis, started with steroids, anti-inflammatory drugs, fever, rash, everything improved. But Anemia persisted. Anemia was not improving. Iron deficiency. By the grace of God, the liver tests were abnormal. Got referred to me for abnormal liver test. When I saw the abnormal liver test, I screened for celiac, and the patient was celiac, did happily ever after that. So his height improved, his weight improved, his hemoglobin improved, his iron. Till last year, we had around 319 patients. Out of that, 225 are typical. That means who come to you with diarrhea. Almost 94 patients of them were atypical, presenting without diarrhea. The increasing awareness, last year we diagnosed 60 more patients. So they present to you with failure to thrive, distension, anemia, short stature, and they could have 50% with abnormal LFT. So I would like to sum up now by saying that they could present you with typical features like diarrhea, failure to thrive, and distension and pain, or with atypical features like anemia, short stature, constipation, obstruction, rickets, vitamin K deficiency, joint problems, etc. To diagnose, you need to do a serological test, a biopsy, and see the response to treatment. Remember, it is a gluten-free for life, not for a couple of years, because it is an autoimmune and a genetically related. Don't forget to screen your diabetics and thyroid. Increasing awareness is the key to diagnosis, and high index of suspicion is very important to diagnose. Thank you for your kind attention.
Thank you. I'll request Dr. Ramesh Datta to give a concluding remarks.
Yeah, see, you would be surprised, like almost I started my practice almost 10 years back when I came back from UK, and I picked up my couple of celiac disease, and there were like 10 pediatricians before that who had not picked up 2 celiac disease for, so many years. And they couldn't, and then it was just in your mind, because we have to realize our genes are the same as Aryans, and I did not have time to show. We were the first one to do an HLA genetic study, and we showed that HLA DQ2 and DQ4, we got an award paper for that, are the same genes as that. And the short stature, I could convince my endocrinologist so much. Trust me, what she does now, the endocrinologist, is she will just screen for celiac. Those who are celiac, sometimes she tells them on the phone, "Aap pehle unko dikha do, uske baad mere paas aana." Because there is, doing all those tests, you just screen for thyroid and celiac. If they are not, then you refer the patient. So one of my major referrals is from an endocrinologist who actually sends to me because she's screening short stature. And in my data, which I was quickly rushing through, 50% of the short stature patients turned out to be celiac disease.
Thank you very much, Dr. Neelam Mohan. Thank you. I'll request now Dr. Manjul Mehta and Dr. N.K. Gupta to please join here and give a memento to Dr. Anil Goyal.